Before we begin, a quick disclosure. This podcast is sponsored by Innovative Hematology Incorporated, a leader in blood disorder care, education, and clinical research. Innovative Hematology may have direct or indirect financial relationships with some of the organizations, products, or companies discussed. Full disclosure and details can be found in the episode show notes. Welcome to We Bleed Too, where women's health meets real talk, real care, and real expertise. Hello, everyone, and welcome to We Bleed Too. My name is Magdalena Lewandowska, and I'm joined by Hilary Gaudreau and Janey VanLiew.
The unique thing about our podcast is that we have different perspectives from a hematologist, an obstetrician, and from a registered nurse.
We're talking specifically about women today, and historically, women are not believed. As a result, women become discouraged, and they don't have the courage to persist in their discussions with their doctors or with people around them or in the healthcare field.
There's been an incredible gender bias, right, in medicine.
Wait, what?
Really, the norms for women haven't been established. They've been excluded from trials. And the feedback that we get Hilary and I kind of do a lot. We do a lot of talks. And the feedback we get from these patients is, oh my God, I had no idea that I had a bleeding disorder. Or I had no idea I meet all these signs of iron deficiency anemia, and yet no one's actually ever tested me for iron deficiency anemia. Or why do people not believe that I actually bleed? Because there has been this common misconception, and I think a part of it may have stemmed from even hemophilia, where women were considered to be carriers as opposed to having a bleeding disorder, that there's this misconception that, they'll go to the doctor and it's well, women can't bleed. What do you mean you have a bleeding disorder?
That concept is so interesting, and as a gynecologist, so foreign to me. However, so actually, interestingly, Magdalena, when you and I were speaking at a national bleeding disorder conference recently, after our presentation, a young woman approached me and asked me for advice. She said, how do I approach my doctor? How do I get my doctor to believe that I bleed? And she told me that she had taken to her doctor's office, a letter from her hematologist, lab results, and as much objective data and information she could to share with this person that as a hemophilia carrier, she actually has abnormal parameters for her bleeding. And I said, you need a new doctor. And sometimes, unfortunately, that is the case, but that's an extreme measure to take. I think the educational piece is what's really important. And I think she had done her due diligence in taking to her doctor all of the information that she had. Unfortunately, her doctor still refused to listen. And again, education starts from the bottom up and from the top down. Sometimes patients do just need to seek another care provider. I think at the end of the day, patients and doctors need to have open lines of communication to allow them to mutually make best decisions for their care.
And make sure, we have the same goal, right? We're trying to empower the patient. We want the best possible outcomes. And so, what I'm hearing, and at the core of my belief system is we need to believe our patients, right? Mm-hmm. So first and foremost, if your patient tells you they're bleeding, we should believe them. Really making sure that we're getting to a point where that patient has all of the tools that are necessary given by their doctors, their primary care, their gynecologist, hematologist when appropriate, to make the best informed decision, right? Back in the day, of course, there was so much more paternalism where you kind of went to the doctor and they told you exactly what you should do, right? And what was wrong with you. And clearly that was not the right way to do things.
Why not even tell you what was wrong with you? They would just tell you what you were supposed to do.
That's a good point.
So I think we've evolved, but we need to continue to evolve. Hence the practice, right?
Exactly. And so, then we kind of had this transition to this concept of informed consent, right? Where the patient, we were well, what do you want to do, right? Say you had breast cancer. It was, do you want chemo? Do you want radiation? Do you want to have surgery first? And it was almost, you're putting the onus completely on the patient, and that wasn't correct either. We've really evolved over time to this concept of shared decision-making, which puts the patient at the center. We're able to have an honest conversation and to deliberate and to talk about the pros and the cons and really allow them to make the best possible decision for them. Let's talk a little bit about the menstrual period. I think there's a couple of topics we should talk about. One of them is sometimes we have these girls who come in, or women. There's a variety. There's like a menu of options, right, that we have in terms of treatment. One thing which we offer is the hormonal versus non-hormonal therapies. We should probably get into a little bit more granular detail on that. But before we do, one topic that comes up is women ask, is it okay if I skip my period forever?
That's a great question. And allow me to look directly into the camera when I say yes. So that's a great question. So, and that touches a little bit on that idea of what's normal, what's natural. So what I tell patients is that it is not normal, it is not natural for a woman who is menstruating, a young girl or a woman who is menstruating, to miss menses, to skip menses, to go prolonged periods of time, to go more than 35 days without of menses, unless that person is being treated with a hormonal management strategy. That could be birth control pills, that could be a patch, that could be a vaginal ring, that could be an intrauterine device. Or if that woman is pregnant, then obviously their menses is not going to occur. It should not occur. There is a real fear that when a person is on a birth control pill, for example, and their menses becomes very light or disappears, there's a real fear that there's some type of harm going on inside their body. And many women and young women think about blood being trapped inside their uterus and it's not coming out, therefore harm must be occurring. So one piece of the educational process is to really explain how hormonal strategies, how hormonal therapies actually work to lighten or to lessen the duration of a woman's menses. And my attitude is every red blood cell that leaves our body is one that's lost and we deserve to have. There is no benefit to losing blood. At the turn of the century,
keep it in your body, right?
This blood stays in your body. No, there is no harm in not having any bleeding. And we strategically approach patients in a way that allows us to have this end goal of no bleeding is the ultimate end goal. So that's a great question. I'm really glad you asked.
Even if people have a diagnosis of bleeding disorder, right? Menstrual cramping, even once the period is relatively controlled, is a real problem. And so can you take us through what are the options if you do have a bleeding disorder of management?
Great question. And I think that historically, women with bleeding disorders are told, do not take NSAIDs or non-steroidal anti-inflammatory medications. So that's always been the mainstay of treatment of painful menses, or what we call dysmenorrhea. And so NSAIDs are Advil, Aleve, ibuprofen, naproxen, aspirin. So when patients have had that messaging repetitively, they feel like, well, then I just don't have any options and only Tylenol is my option, it can be an option, but it doesn't tend to be effective. Exactly. Tylenol treats fever and pain, but it doesn't address inflammation. So when I talk to women about their options for cramping or pain with their menses, I tend to start kind of at the bottom of the list of interventions, and I'll talk to them about, something as basic as using a heating pad or anything that gives them warmth. And if they apply it to their lower abdomen or their back, that can be really, really helpful. And also magnesium. And there are lots of magnesiums out there, but magnesium glycinate. It's a mineral that can help with muscle cramps. And it can help with muscle cramps in the body, any muscle, but specifically it's really effective for menstrual cramping. And it does not increase a woman's tendency to bleed. Is that correct?
Oh, yeah, absolutely.
Great, because I've been recommending it. So
great.
Okay. But I think the medication that is very often underutilized is celecoxib, the brand name being Celebrex. And that is that magical unicorn in the category of nonsteroidal anti-inflammatory medications. Of all of those medications, and we're always repetitively telling patients with bleeding disorders to avoid those, celecoxib is perfectly safe. And as I understand it, doesn't affect platelets and how they work.
Mm-hmm.
And it is a prescription, but knowing about it is important so they can ask their doctor. And that particular medication is really effective for helping cramping. And it's also FDA approved to help treat dysmenorrhea or painful menses.
And thanks for sharing that. I mean, I think, classically we talk about how Tylenol or acetaminophen is fine, but Celebrex is great. And I mean, I'm happy to go into pathophysiology with anybody, but basically, it doesn't make platelets not stick together, right? It doesn't prevent them from sticking together, which a lot of the other medications do. It has the same side effects as other non-selective anti-inflammatory.
Is it safe to take every day?
I mean, for certain patients, yes. And I would totally encourage people. Yeah, it depends on the indication. But I mean, honestly, for most patients, especially who are young and healthy and don't have any kidney issues, then yes, it is.
Do women ever get addicted to?
No. So it's not the type of medication. It's not an opiate. It's not something that causes addiction.
A little bit of a side note. I think the advent of the smartphone has been wonderful because as a result, women feel compelled to literally take pictures of the blood that they're losing to share with their doctors. And I encourage women to do that because this empowers them with a visual that everyone can understand, regardless of your educational background, your gender, your cultural background. And
it's going to be a lot of pictures coming everyone's way.
It's just blood.
Yeah, no, it is just blood.
It's just blood.
Yeah.
So we bleed. Women are not always believed. Empowering women with ways to allow them to effectively communicate and be believed is really important.
There's about 2 billion people who have anemia worldwide.
Attention shouldn't be given to the gas tank when it's sitting on empty or past empty.
Yes.